Hi, Vinya.
Hi, my speaker.
So it's live now, and now I would like to share my screen.
दी आपका स्क्रीन बहुत अच्छा लग रहा है, बैकग्राउंड इज टू गुड.
Thank you. So welcome to the first episode of Twilight by Raipur Menopause Society. This is the first webinar of the series, and the topic is the breast. So today we have two speakers who are going to speak on that, and then we are going to have a scintillating panel. I invite everyone to join me in taking the blessings of the divine before we start the program.
वक्रतुंड महाकाय सूर्यकोटि समप्रभा निर्विघ्नं कुरु मे देवा सर्वकार्येषु सर्वदा. असतो मा सद्गमय तमसो मा ज्योतिर्गमय मृत्योर्मामृतं गमय. ॐ शान्ति शान्ति
I invite Dr. Ritu Shilpa Verma to introduce the organizing team.
Good afternoon, everyone. I would like to introduce my very special ma'am, Dr. Asha Jain ma'am. She is a president of RMS at present, and she is director of SMSA Hospital, Raipur, medical director of Cancer and Prevention and Relief Society. She is past president of Raipur Obs Gynae Society 1822, and we don't require her introductions because next is Dr. Shalini Jain Agrawal ma'am. She is director consultant at Saubhagya Mother and Child Care Hospital, and she is secretary of Raipur Menopause Society. And next, Dr. Monica Pathak ma'am. She is consultant director at Sai Srusha Hospital. She is laparoscopic surgeon, specially trained in obsgynic and ultrasound. She is secretary in Raipur Obs Gynae Society 2022-24 and treasurer in ROGS in 2018-22.
She's the treasurer of
Raipur Menopause
this
Society.
Raipur Menopause Society, incoming president of Raipur Obstetric Gynec Society, and the digital committee IMS chairperson, Dr. Sushma Verma, who's the director and consultant at Sarvodaya Hospital and Maternity Center, Test Tube Baby Center. She is the immediate past president of Raipur Menopause Society, and her fields of interest are laparoscopic pelvic surgery and infertility, high-risk pregnancy, and menopausal health. On behalf of the organizing team, I welcome everyone to this first episode of Twilight. This is named Twilight because as the day goes off, there is a very auspicious period, which is the twilight or the Godhuli Vela, in which if correct steps are taken, the evening and night becomes blissful. So we want every lady in the twilight of her life to learn and train herself to make the evening and night of her life beautiful and happy. So now we are going to have the first session. The first session is on breast examination, a basic thing that everybody should know. I would like to introduce the chairperson, Dr. Vinya Maiskar, and then request her to introduce our speaker, Dr. Rajni Saul. So, Dr. Vinya Maiskar is an MBBS, MD, and FMAS consultant at Sri Narayana Hospital and Avni Clinic, Raipur. Her areas of interest are high-risk obstetrics, assisted reproductive technology, and gynec endoscopy. She is a faculty speaker in state and national conferences. She's published papers in Jogi. She's a peer reviewer in Jogi and Journal of Midlife Health. She is a life member of many societies, author of the book Home Care and Parkinson's Disease, and she is also in charge of the new incoming newsletter of Raipur Menopause Society. So welcome, Dr. Vinya. Over to you to introduce Dr. Rajni.
Thank you, Dr. Asha, for your kind words. And it gives me immense pleasure to start with the first episode of Twilight and with the new team of RMS, which I am also an executive member, very happy to be. And Dr. Rajni Saul is also the executive member of the new team. She is MD, DA, and she's the director of Karma Hospital. She has been the past president of ROGS 2008 to 2010. Member of Practical Obstetrics Committee, FOXY, and she has been a General Secretary of Raipur RMA, also General Secretary of Raipur ONG. She's a very well-known figure in ROGS, and she's interested in a lot of arts and dance forms, I would say. And with these words, I like to invite you, Rajni Madam, for our talk on breast examination, which is the first talk of our Twilight series. Welcome, Madam.
Thanks a lot, Vinya, for those good words. And I am starting sharing of my screen.
Dr. Rajni, will you be able to do it or you want me to do it for you?
No, you do it, please, ma'am. Unsupported RMA. Thank you so much. So,
just go ahead and just tell me when to go next.
Yeah. So we started the breast examination, and I'm Dr. Rajni Saul. Next, please. So, just running over the anatomy of the breast, you can see the areola, nipple, and the breast tissue and the lymph nodes. Next. And just with the introduction that breast self-examination can be taught to individuals or to the groups, what we are doing at present. And this is best performed after menses from day 5 to 7 of the menses. For the postmenopausal woman, once a month, many women have grainy texture. This has to be kept in mind in the breast tissue. But this area will usually less nodular after menses. So sometimes the people do come, women do come, the girls do come to us saying that there is something inside the breast, please palpate and tell us. So we do it. So ideally, the examination should be done on the day 5 to 7 of the menses. Next, please. So this is the just a pictorial view of the how the breast self-examination is done. Next. And next, please. So the definition is definition of BSE, what we call it as in the short form is, this is a screening method which is used in an attempt to detect early breast cancer. The method involves the woman herself looking at and feeling each breast for possible lumps, distortion, or swelling. Please, next. So breast self-examination purposes is to help to increase the breast awareness, and it helps in early detection of the breast cancer. Next. So these are the steps, the 5 steps, and it involves the inspection and palpation. Next. So the preparation is the best time to do a breast self-examination is a few days after your monthly menstrual cycle end, and the hormonal changes that affects the size and the feel of your breast. So it is best to perform the examination when your breasts are in the normal states. So women who do not menstruate should choose a certain day to perform the examination, such as first day of each month. You should also keep a diary or journal of your self-examination. This will help you in tracking and recording any changes you have noticed in your breast. Next. So inspection, this is the step 1. And how to begin? You begin by looking at your breast in the mirror with shoulder straight and your arms on your hip. So breast, and what should you look for? That is breasts that are in, whether it is in usual size, shape or color, and the breast, they are evenly shaped without any visible distortion. Next. So you have to watch for whether there is any dimpling, there is any puckering or bulging of the skin, a nipple that has changed position, or if it is an inverted nipple, you have to make a mark. Any redness, soreness, rash or swelling has to be marked. Next, please. So steps in the breast self-examination: inspection before a mirror, palpation in the lying down position, and palpation in sitting or standing position. Next. So step 2 is now, after doing a self inspection, now the step 2 is to raise your arm and look for some changes if there is. And step 3 is, while you are at the mirror, look for any sign of fluid coming from one or both nipples. It can be watery, milky or yellow fluid. Likewise. So next, step 4 is you feel your breast while lying down, and it is very important to feel it with the pads of the 3 fingers of the right hand to feel your left breast, and left hand to feel your right breast. Use a firm, smooth touch with the first few finger pad of the hand, and keeping the finger flat and together. Use a circular motion and about the size of a quarter. So you can do from upside down in a rounded way, from outside to inwards or inward to outside, like that. But it should follow a pattern. Next. So like this, you can swipe from up to down, from clavicle to down, then up, then down, up and down, just like a patterns, any of the patterns you can choose and do it likewise, so that nothing, not a single tissue is left behind for the examination. Next. So cover the entire breast from top to bottom, side to side, from your collarbone to the top of your abdomen, and from your armpit to your cleavage. So follow a pattern. Next. Next. So, and the final step 5 is finally feel your breast while you're standing or sitting. Many women find that the easiest way to feel their breast is when their skin is wet and slippery, so that they can palpate it so easily. So they like to do this step in the shower. Cover your entire breast and using the same hand movement that is described just earlier in the step 4. Next. So advantage of self-breast examination is that it allows each woman to control over her own health, provides each woman knowledge of what her own breast tissue feel like, and it is non-invasive. It is a simple procedure and it can detect the breast cancer at an earlier stage if uh, uh, and if those women who are not performing this, they will miss this diagnosis. Next. So there are certain disadvantages also, because some कुछ औरतें ये सोचती हैं कि अरे हम एग्जामिन करेंगे और कुछ निकल जाएगा तो हम क्या करेंगे. So this fear and anxiety about what may be found during the examination and the false positive, which is the result that indicate that a condition is present, whether it is a lump or not, like this. So the lack of confidence is the barrier. Next. So the clinical value is very obvious. Experience has verified that 90% of the breast cancers are found by the woman themselves. When the woman discovers lump in their breast at a very early stage, the surgery can save 70 to 80% of the proven case. So it has a very renowned clinical value, the breast self-examination. So there are recommendations that all women of the age 20 and above should perform this, and the women 20 to 39 should have clinical examinations also. All the women at the age 40 or older should have regular mammogram, and the asymptomatic women aging 40 and older should continue to receive clinical breast examination, preferably be a part of a periodic health checkup. So screening decision for the older woman should be individualized by considering the potential benefits and the risk of mammography in the context of the current health status and estimated expectancies. Next. So now, when this patient after breast self-examination comes to doctor, and so what next is to be done by the doctor is again by the physical assessment, either done by the inspection or palpation. Next. So by inspection, the breast should be symmetrical, it should be full, rounded, smooth in all the portion, without dumpling, retraction, or the masses. Even the vascular pattern has to be noted. The nipple, whether it is everted or areola is around, is also to be marked, and the examination of the axilla and the color and the masses and without that has to be noted. Next. So in the palpation, it is just done as likewise as we have done in breast self-examination, and we have to see whether it is firm with or without masses, whether lumps are there, local areas with warmth or tenderness is there, the nipple should have no discharges, axilla should be smooth, and there should be no node palpable. Next. So when these patients come to us, we doctors, we the gynecologists, bring about an assessment interview about the patient's breast history and the sexual health history, whether they are currently active sexually or not, whether they are sexually active and they have the sexual desire, the sexual in the during the act of the sex, whether they are experiencing any pain in the breast or not. This all has to be inquired, and any illness and the partner concerned about the future sexual functioning, all this has to be the question to be asked in the interview to assess the sexual health of the patient. Next. Regarding the breast history, you have to ask the client about the breast pain or tenderness and its occurrence in relation to the menstrual cycle. This is very important. So with this, we can assess whether it is a fibroadenoma or adenosis likewise. And this topic has to be taken later on. So we have to ask the woman whether they have currently any breast lump or the masses, or if lump is present, ask the woman to describe its location, onset, size, कैसा था, कब से हुआ, कितना टाइम हो गया, बढ़ रहा है कि छोटा हो रहा है, दर्द हो रहा है कि नहीं हो रहा है. Determine whether the lump has changed in its size, consistency, degree of redness since it was first noticed, and ask about the nipple discharge also, and ask whether the patient has performed the BSc self-assessment of the breast regularly, and whether the woman include axillary notes also in the BSc. So ask about the history of the breast cancer in their blood-related female relatives, mother, sister, maternal grandmother, or maternal aunts. It indicates an increased risk of breast cancer, and if she has any family history of the breast cancer. Next. So by doing this assessment, we identify the client at risk, and those patients who have altered body structure or function due to trauma, pregnancy, recent childbirth, anatomies, abnormalities of genitalia or diseases, physical, psychological, emotional, sexual abuse, sexual assault, disfiguring conditions such as burn, skin condition, all this have to be noted, and specific medication therapy has to be noted. Temporary or long-term impaired physical ability to perform the grooming or maintaining the sexual attractiveness is also attached to this examination and everything. So the value conflict between the personal beliefs and the regional doctrines, and those clients who have lost the partner or the lack of knowledge or misinformation about the sexual functioning or expression, these patients also have to be identified, and they have to be given the accordingly the education, health education. And so the women are screened for the breast cancer in 3 ways. One is mammography, in which the X-ray is done without any injection of the contrast medium, and 3 views are taken: the craniocaudal, the mediolateral, and the axillary. Next. So these are all the examination, and next screening is the clinical breast examination. We just talked about the inspection and palpation and the breast self-examination. So all these are the screening tests. Next. So whenever we get a lump or something suspicious, we either do a biopsy, or if it is a smaller, so we do a excisional biopsy and get it checked. Either we do an aspiration of the cyst, or a small nodule like that, or incisional biopsy is taken, and that is sent for the pathological examination. Next. So with this, I complete my examination of the breast, and we have to be very, we have to be aware and should take action, so that being aware and take action is a line further to fight the breast cancer. And next. So let's fight against the breast cancer. And I'm Dr. Rajni Sao, and thanks for the patient hearing. Thank you so much.
Thank you, Dr. Rajni Sao, madam. I think it was a wonderful lecture. You covered all the aspects of breast anatomy, the structural changes, the nipple changes, and the discharges too. And I would like to emphasize on one point which you already covered, that breast self-examination is very useful in first-degree relatives of cancer breast patients. Like if a
Exactly.
mother has, and then her daughter is in 40s and 50s, and she tells, like, for checkup, that my mother had a cancer breast. So you must advise them to do a self-breast examination. And I have such patients who have diagnosed it themselves, and they later on turned out to be CA breast. So breast self-examination is one thing which is very important and which the patient can herself do and come to a conclusion that there is some abnormality in a breast. So thank you very much, Dr. Rajni
Thank you.
Sao. It was a
Thank you so
wonderful.
much, Vinya, for chairing the session. Thank you so much.
I would like to add one thing here, and that is actually contrary to what you're saying. Examine your breasts and be unafraid, because not every lump is cancer. When you examine the breast and you see lumps, then 60% of the time when you're young, it will not be cancer. Even if you are elderly, even then, less than half will be malignant. So just relax and examine, because that way you are giving yourself a certificate of health and not of disease. And if you find something wrong, you can just go ahead and get it treated. Because the first step is self examination, and the next is to go on to a clinician and get it
Yeah.
treated.
Yeah.
So,
After
for everyone who's
examination,
listening, I would like to say not every lump is cancer, and not every cancer has a lump. So let us be aware and proceed from that. So, anybody wants to add anything else here? Dr. Yashwant, if you are listening, would you like to give an expert comment?
Hello. Yes, ma'am.
Means you've heard the lecture, so would you like to give an expert comment before we go to the next lecture, that now we have found a lump and what's going to happen?
Ma'am, ideally, uh, as ma'am has clearly explained about when we should be high alarm regarding the lump, and every lump which is not mobile, hard fix, or increasing in size and other parameter, then it should be evaluated. And technically, we do triple test like biopsy.
We'll come to that in the panel.
Yes. Okay.
That is the next lecture.
Yes,
That's not
ma'am.
what I'm asking you. Just to the examination, if you wanted to add anything. Otherwise, we go to the next lecture.
Any confusion, I think it should be double checked, because many a time in if beginner will palpate, then he will fill many lumps, so it should be reconfirmed.
Okay, thank you. So now I would like to introduce our second chairperson, Dr. Jofi. She is an MD obstetrics and gynae from CMC Ludhiana. She is practicing as consultant gynecologist at Dr. Jofi's Wellness Clinic and Ashoka Super Specialty Hospital. She has worked as consultant at Apollo Hospital, Gurgaon, Haryana. She has membership of Raipur Obstetric Gynae Society and Indian Menopause Society. Special interests are high-risk pregnancy and endoscopy. She is the winner of the North Zone Foxy Quiz competition, and she's published many research papers. Over to you, Dr. Jofi, to introduce Dr. Veronica.
Hello, everyone. I hope I'm audible.
You're audible, and now you're visible.
Okay. Hi, everyone. So I'm Joffrey here, and thank you, ma'am, for that introduction. Thank you so much. And it's always a pleasure to introduce a fellow senior. Dr. Veronica Irene is also my college senior from Ludhiana, and she's a national well-known faculty of ISAR, IFIS and FOXY, and she's currently the joint treasurer of Chhattisgarh ISAR. She's also been the assistant secretary ISAR Chhattisgarh from 2010 to 2020, and is a member of FOXY Infertility Committee from 2007 to 2020. She has multiple papers to her credit, and she's also published multiple chapters in reputed index, national books, and journals. Welcome, ma'am, and hoping to learn a lot from you. Thank you so much.
Thank you, Jofi. The best part is both of us belong from the same college. So that's an added this thing, being Jofi, being my chairperson for this session. At the outset, thank you, Raipur Menopause Society, for this opportunity. Thank you, Asha ma'am, and all the other faculties, Dr. Shalini being the secretary, and it's a pleasure to be here. Now, most of the things that I was supposed to take, I think ma'am has covered, Dr. Rajni has covered some most of it. I was under impression ma'am is going to take the genetic aspect of it, but never mind. Since we have a lump.
May I interrupt for a second, Veronica? Requesting everyone, please put on your video so that we can have a photo for the record, and then Veronica can share her slides. We need a photograph for the record. Dr. Rajni, everyone, please put on your videos. Nirja, you've disappeared. Closer, closer. Come closer. Yes. Okay, thank you. Now you may please proceed.
Thank you, ma'am. I think flyer mein my name has been written wrongly.
What's written?
मोनिका लिख दिया मैम, मैं वेरोनिका हूँ. नाम एक्सचेंज हो गया, I think. मोनिका मैम.
It has been corrected. It has been corrected. I have the correct one here, which is the one that we have circulated.
Yeah.
Okay?
I told the flyer person also twice and messaged him also.
No, it has been corrected.
Yeah.
So, can you all see the presentation?
We can see it, Dr. Veronica. You need to make it full screen.
Okay. Right. So we all know that breast cancer is one of the most commonest cancer in the world, and the incidence is going on rising. And actually, this has led to a lot of awareness being risen among the not only the senior people category, but among the youngsters also. Now, more than 3/4 of these women in developing countries have been found to have diagnosed with advanced stage of the disease. Therefore, it becomes mandatory, or rather, it is important on our part to evaluate and take a closer look at all the patient and detect breast cancer earlier. Now, if we look at the screen, this is the 4 commonest cancers that are happening: breast, cervical cancer, ovarian, and corpus uterine. And if we see, look at the graph being marked at yellow, breast cancer is rising exorbitantly, rather I should say, worldwide. So there are various risk factors that attribute to breast cancer. That is, one thing is a female who is mainly in the estrogenic phase of her life, that is reproductive phase of her life, especially suffering from conditions which lead to hyperestrogenism, early onset of menopause and late onset of menopause. Multiparous ladies can also have, childbirth delayed can also have, ladies who are on long term hormone replacement therapies carry an increased risk of 30%. Ladies on oral contraceptive pills and those who have received prior radiation exposure to breast at a younger age. Various other diseases, breast diseases itself predispose these ladies to breast cancer, that is, those suffering from atypical hyperplasia or intraductal carcinoma in situ, obesity, diet risk coming into picture nowadays is those that carry a genetic risk factor, that is the genes that they are carrying. So there are various types of breast lumps. Now, breast lump can be benign and malignant. Benign ones can be, the most commonest one that we encounter is fibroadenoma, and among the malignant one is the ductal carcinoma in situ or the invasive carcinoma in situ. Rarely we do see other types of breast lumps. Now, what happens? So, should all breast lumps be evaluated? Now, how do we feel? The most common lump that we feel is a ridge or a normal breast tissue whenever a lady comes to us. In younger women, cancer is uncommon, but nevertheless, it does exist. So we should evaluate them. And the most common feel of a breast lump is of a benign nodularity kind of feel, followed by a fibroadenoma, which is usually firm to cystic in consistency and highly mobile. Now, this chart, this graph that I am showing is the various types of lumps present and their corresponding age group in which these kind of lumps are present, lumps are seen. I have depicted in this picture. So majority of the breast cancers, initially when they come to us, they present as lump, and therefore all breast lumps need to be evaluated. So how do we go about it? Now, the gold standard that has come in the form of modality that we have to assess these lumps is, it consists of three parts known as the triple assessment. That is, one is the clinical assessment, followed by imaging, and a confirmatory diagnostic tissue biopsy that confirms. Now, if we apply all three, the diagnostic accuracy of this test or the triple assessment test comes to as high as almost 100%. So, coming to the first step, that is clinical assessment. Clinical assessment consists of two major steps. One is the history. History itself will tell you, it will hint you whether a lump is benign or malignant. Predominantly the age, if there is any previous history of any breast biopsy, recurrent lumps forming, trauma, a lump that is progressively increasing, hard, any nipple discharge associated with it, family history, and number of pregnancies a lady has had, followed by the clinical breast examination, which Dr. Rajni has covered in depth. So I would then consider the following when you are assessing a patient with breast lump. First of all, when you are assessing the patient with a history, there are certain red flag symptoms which should guide you whether a patient is having a malignant or a benign lesion. Red flag symptoms include mainly breast or axillary lumps, if the breast lump is associated with an axillary lump as well. Associated skin changes, unilateral, also association of a nipple inversion associated with it. Then a lady who has had an exposure to estrogens, these are associated features: age, menarche, breastfeeding, ladies on hormone replacement therapies, oral contraceptive pills, obese, religious groups which have a higher propensity towards. So the next step, a part of the triple assessment test, is the clinical examination. Now,
Veronica, we
clinical
can't see your
examination
slides
has
anymore. We can't see your slides anymore.
now.
No. And you had gone silent for quite some time.
I'll
You'll have to share again, please.
yes, I'll do that.
Some network issue.
Just 1 second.
Just check it at your end. The network issues.
I'll share my screen again. Now can you see?
No, not visible
We
now.
can just see started screen sharing, but we can't
But
see anything else.
now it is
Now
visible.
we can see it.
Okay. So, I mean, till where
Red
I
flag
had
signs
gone?
you were saying, no? Red flag signs.
Okay. So when you assess the history part, there are certain red flag signs that we need to be vigilant about, and they hint us towards a malignant part. These signs may be breast or a presence of an axillary lump along with the breast lump, associated skin changes, also associated
Dr. Veronica, again you are mute and you are not visible. And your slides are also not visible.
Veronica, can you send me the slides? I will play them.
uh, okay, should I send you on mail?
You can send on WhatsApp or mail, whatever you wish. Just tell me where you're sending it.
Okay, just give me a minute. I'll just send.
While Dr. Veronica is managing it, I would like everyone to put on their videos and just tell me how many of you are actually advising your patients to go ahead and do a breast examination? How many of you are training your patients for it?
Yeah, I am advising always to all the patients.
I'm not asking you, Shalini. We have a lot of guests, right? So, what about our guests? All of our guests who are here, how many are actually advising that go ahead and do a breast examination? Are you demonstrating it yourself or are you asking your staff to do it? Dr. Joffe? Just unmute yourselves while this thing gets sorted out and let us give the viewers something to listen to.
I also advise the patient, especially the patient of fibroadenoma, fibroadenosis, especially to them, I advise for the breast examination.
Yeah.
Yeah.
But you know something? That it has to be for everyone. Yes, Dr. Chetna, welcome.
I actually write, yeah, good afternoon, everyone. It's great to see you all. I actually write on this thing also on paper. In my prescription, the first thing is SBE, that is the short form for self-breast examination. So that if they, when I tell them also, and I write there also, so that they remember it.
See, if you would write SBE to me, I would not understand what it
No,
means.
I will first. No, I write the full form and short form both, and I will tell them also. This is self-breast examination.
Because I remember when we were students, Dr. S.R. Gupta sir used always to say, don't use any short forms on your paper because you may understand it, but the patient doesn't understand it. And आपके सामने वो समझ लेगा, बाद में भूल जाएगा. So do you demonstrate it yourself or do you ask your nurses to demonstrate it?
No, I do it myself. I will only tell them how to examine.
Okay. What about you, Dr. Joffe?
Hi, ma'am. So, yeah, I mean,
Hello.
to be honest, if it is a busy PD, I don't think I do it for everyone. But then, yes, if you have time, and then, yes, indeed, I do try to explain. But the nurses can't do it, so I don't tell them to do it. I do it myself. For the ones I am telling, I do it myself. I don't depend on someone else to tell. Yeah.
Yeah, but see, that means that a majority of your patients are not getting the benefit. So here what we are discussing is train one or two of your senior staff. so that they can, when the patients are waiting in the OPD, you're not seeing each one of them together. So she can explain, you can have some charts there, and your senior nurse can explain, and you can reinforce. It will take less time, and no patient will be missed. If I have the time, if there is fibroadenosis, I will explain. So a large number are being missed. And our target now is that nobody should be missed, because now India has reached breast cancer as number one. And we used to think it is a disease of the affluent. Today, even the poor women are getting it. A lot of poor women will have breast cancer. When you go to slums, you go to Anganwadi Kendra, you will find that, women who have nothing, they also have breast cancer. So we need to understand, we think breastfeeding has a great benefit. Yes, it does, but not always. Not always. So every woman has a right to breast examination, and we are in the right place to do it. Whether we do it ourselves or we train one of our senior staff to do it, a couple, because if one is doing it, she'll get bored and she'll run away. If there is a competition between 2 or 3 nurses, they do it better. So anyone wants to add anything? Sanjita?
Ma'am, can we have any charts that can be self-explanatory to patients? Can you suggest something like that?
See, just now Veronica demonstrated some. Before that, Dr. Rajni also gave you some slides. Now this is going to be present on YouTube forever. We can take screenshots and we can make them, or our friends will share the slides with us. Yeah. Otherwise, I think in this newsletter, we are going to have that self-breast examination ka poster, which we are going to have for everyone. So that should work.
Thank you.
Hi, ma'am.
Is Veronica here or she is not here? Yes, Chetna?
No,
Hello,
I just
Preeti.
saw Dr. Preeti and I was waving to her.
Hi.
So, Dr. Preeti, you want to add something about self-breast examination?
Yeah, what I have done for patients education, I've like in my reception area, I've put certain posters, and also a TV is playing over there that shows this thing SB for most of my patients, and then the patient comes inside. If she has any problem, if she has any this thing regarding lump, then I ask her, did you learn this thing from? Then I ask her to demonstrate. And then I tell if I correct if she is wrong somewhere.
Okay. So now, because Veronica is not able to join, let us start with the panel, which I hope will cover everything. So we have a person of great value, Dr. Yashwant Kashyap, who's right now working in Balco, but I've known him since his AIMS days. So he is MD in General Medicine from Varanasi and DM in Medical Oncology from Tata Memorial Hospital, Mumbai. He has 8 years of experience, specializes in breast and lung cancers, GI and leukemia. So welcome, Dr. Yashwant. I would request you to introduce I'll introduce the panelists in short. So we have Dr. Preeti Singh, who's practicing for the last 23 years in Devi Women and Child Hospital. Dr. Rashmi Sood, who's the director of Guru Kripa Nursing Home. She has RMS and ISOPAB IFS membership. She's also our joint secretary currently. Executive member of ROGS, Dr. Reema Dilavari, consultant at Gyan Devi Clinic, Devendnagar, Raipur. We have Dr. Sanjita Pal. She's trained in Foxy, ultrasound and colposcopy. She is a member of ROGS, RMS and ISOPAB, and she has a gold medal from ROGS in paper presentation. She has a gold medal. Dr. Ritu Shilp Verma, consultant at District Hospital Durg, trained in Foxy certified ultrasound course, lifetime membership in RMS and ISOPAB. She is an executive member of RMS, Dr. Kritika Verma. Again, she has done her ultrasound course, Foxy certified, member of ROGS, RMS, and ISOPOC, has won a prize in poster presentation, has published case report and original research work in international journals. Amongst these newcomers, we have Dr. Chetana Ramani, a senior consultant at Ramkrishna Care Hospital, Raipur, has the Nest Mothers Clinic, member of Sankalp, life member of IMS and SFM, and has special interest in medical disorders of pregnancy, critical obstetrics, contraception, and menopause. So with this, I stop sharing. Veronica, you are back. Would you like to go ahead?
Yes, ma'am. I've sent
So you
my
go ahead,
presentation.
and I have introduced. How many minutes of your presentation remain?
I think 5 more minutes.
Yeah, you please finish it, and then Dr. Yashwant, you can share your slides.
Okay. Ma'am, you will be sharing my presentation?
Where did you, what did you do with it?
Okay. I have
You
sent
mailed
you
it or you WhatsApped it?
I have WhatsApped it. I have sent you.
Okay, let me have a look. Yes.
नहीं तो मैं शेयर कर सकती हूँ दोबारा.
ना मैं अभी एक सेकेंड में मैंने डाउनलोड नहीं किया है. I'll just do it. Done. Which slide were we on?
Red flag symptoms. Assessment. ऊपर ma'am, ऊपर.
Slide number 11, ma'am.
हाँ. So the first thing that we go in the clinical examination is when you are assessing through the history. Now history, we should be careful. There are certain symptoms that guide us whether a lump is malignant or benign. That is, there are certain red flag symptoms known as where there is an associated axillary lump along with the presence of a breast lump. Associated skin changes may be there. Unilateral bloody or clear discharge and a nipple eversion is also present. Along with associated history of exposure to estrogens may or may not be there, characteristically marked by age, menarche and menopause, parity and breastfeeding, where there is a history of HRT or a lady on OCPs, obesity and alcohol consumption history. Something that is very, very important is where there is a family history. Now, this is something that carries because this is also associated with a genetic component. So, these patients are to be assessed for genetic markers as well. Then breast cancer occurring in less than 50 years of age, bilateral breast cancer, associated history where if it's in the family that any male has also suffered from breast cancer, associated breast and ovarian cancer in the family, and some religious groups, there is a predominance of having malignant lumps. Next. So the next part is the clinical examination. Most of it Rajni ma'am has already covered it, and something that this I thought ma'am has most of it. She has covered it, all the positions, how we should be relaxing the patient. I would not go into the details of it. We can skip all this and go ahead. Now, on the basis of examination findings, whether the lump is malignant or benign, again comes the question, what should be done? There are various malignant lumps. Malignant lumps, how do they appear on examination? They are usually hard, they are painless, irregular, fixed to the skin or chest wall. They may be mobile, but usually the mobility is restricted. Associated skin dimpling may be there. There may be nipple retraction or presence of a discharge, serous or a bloody discharge. Usually, benign lumps are firm to rubbery in consistency. They may be mobile. Some of them are painful if they are infective or inflammatory. They have regular and smooth margins. They are mobile and very rarely associated with some kind of discharge, which may be green or yellow because they may be infective. If clinical examination suggests a benign lump, should we go ahead with triple assessment? Now, this is the question. So, I'll come to the same question after 2-3 slides, because there are various different modalities of imaging that helps us how the breast lump should be assessed. Should we proceed further with other forms of imaging modalities? So the various modalities that are now available to us is mammography, ultrasound of the breast, both mammography and ultrasound, and MRI of the breast. Coming to mammography. Now, this mammogram is an X-ray procedure where all women above 30 years of age or older with a breast mass can be prescribed because can be prescribed. Now, there are associated spot compression views and magnification views are recommended in this mammogram when it is being conducted. This can also be a part of a routine screening program, can be offered to women in all age groups coming to us with a breast lump. Multifocal or multicentric disease can be evaluated. No, you have gone ahead. Yes. However, there may be an overlap which may exist between the mammogram appearance of a carcinoma or a fibroadenoma. So the next modality, commonest modality that we have is the ultrasound breast, which is also considered a diagnostic test of choice in patients with less than 30 years of age, because ultrasound limits the exposure to X-ray to young women. It differentiates between cystic versus solid areas. It may identify simple or complex cyst architecture. Guided biopsy is possible through an ultrasound, highly operator dependent and subjective, and an overlap may exist between the ultrasound appearance of carcinoma, fibroadenoma, phylloid tumor, and a complicated cyst. The next modality available is MRI breast. It's a useful screening tool in high risk women. Not all should be offered this, but it is the most sensitive for detection of lump, what kind of lump it is. It's one of the best imaging modality in women with breast implants. However, it also has a high false positive rate. Next. So, keeping in mind all the three modalities of imaging that has been a breast imaging reporting and data system was advised, which is commonly known as the BIRAD. Now this BIRAD helps us in planning which patient should be subjected to a more rigorous testing and some of the and which patient can be left alone. Now our scoring criteria was given, which is now known as, which we report it as BIRADS 1, 2, 3, and 4. And based on this, a person where the risk assessment comes as, where the scoring comes as higher from 3 to 4, these patients have a higher chances, these lumps have a higher chances of being malignant, and therefore such patients should be recommended a higher testing. That is, these kind of patients should be subjected to a more diagnostic approach, that is towards the biopsy, which will confirm the diagnosis. Next slide. So this is the scoring that is being done just to help you. Score 1 to 3 should be followed with an ultrasound. Score 4 to 5 requires a tissue biopsy, and score 6 is given after a biopsy is cancerous. So which imaging modality would you prefer? Mammography is one of the modality where it helps us in detecting a carcinomatous lesion which has a similar sensitivity and specificity to ultrasound. However, in young patients, next slide please. However, in young patients, ultrasound is the preferred modality of imaging. So when you are coming to if your BIRADS is coming high, you definitely have to subject these patients to the tissue diagnosis. Now, tissue diagnosis can be achieved either through a fine needle aspiration cytology or a core needle biopsy or an excision biopsy. Now, this is the third step that is coming in the triple assessment test. Or the triple assessment criteria. FNSC can be done via 22 to 26 gauge nasal, fast and easy to perform, and can be done in the OPD basis. However, it does not show a histological architecture and at times cannot differentiate between the carcinoma in situ from an invasive malignancy. The next one is core needle. Core needle biopsy is done using a true cut biopsy, and you have to decide whether an FNSC or a core needle biopsy on which patient we need to subject. If you are thinking that it if on your history and clinical assessment, if it is indicating towards a malignant, definitely we should be going towards a core needle biopsy, which is very easy to perform and can be done by either a surgeon or a gynecologist or an oncologist, anyone. So this is the most diagnostic and should be performed on a patient where you are suspecting a more of a malignant lesion. Next slide. However, the current practice is that core needle biopsy is preferred for every breast lump. FNSC is not recommended nowadays, and excision biopsy can be done in a case of discordance. So the algorithm that has developed is whenever a patient of breast lump is coming, assess the patient through the history and clinical examination, assess if it is benign or malignant, subject them to the most suited imaging test that is required, followed by a confirmatory test either through a core needle biopsy or an excision biopsy. This is the triple assessment that is being done and followed. Any role of genetic testing in these patients? Yes, where there is a history, and if it's subjecting towards a malignant lump, yes, a genetic testing is required in these patients. We can slip the next slides. Now, this is the various, ma'am, that was one of the last slides. इसके बाद एक दो स्लाइड और है, पीछे वाला स्लाइड. Now various societies have recommended what is to be done, and all the societies, they have come to the triple assessment scoring, that triple assessment test that needs to be done for all the breast lumps that is being therein, depending upon the severity and the BIRAD staging of that patient. Next. So, do all breast lump need triple assessment? And the answer to this is yes. All breast lump need a triple assessment, but the severity of the test, I mean the imaging test and all, that can be individualized as per the need of the patient. Next slide. So, to sum up, all palpable mass in women's breast could be a potentially serious lesion, and all of them should be evaluated. A triple assessment is an effective strategy in all these patients. Subject them to the proper imaging study and always exclude a cancerous lesion by either a core needle biopsy or a excision biopsy. Just anybody, either of them can do the excisional.
Thank you, ma'am. Thank you so much for a detailed discussion of this. And I would just add on to it. Nowadays, for the term breast self-examination, the newer term that has been come is breast self-aware. So the lady should be aware of the breast. So instead of self-examination, the lady should be breast self-aware. And the second is usually that they say is FNSC, as you have really highlighted well, FNSC is now no more done or prescribed. You should straight away go for true cut biopsy or a core biopsy. Thank you so much again, ma'am, for a detailed, really nicely discussed. Thank you so much.
My pleasure.
Thank you, Veronica. And thank you so much, all the panelists. We are just 5 minutes late, so we'll finish on time. Over to you, Dr. Yashwant, to take the program forward. You may start sharing.
Thank you, RMS for thank you, Asa Jain ma'am. Thank you, RMS, for inviting us. It gives us immense pleasure to discuss about cancer in any platform, and I am fortunate that I will be discussing, and also apart from me, my colleague Dr. Rakesh Mishra is also there. Dr. Rakesh is medical oncologist and encyclopedia of our medical oncology, and he is consultant from Sanjeevani Cancer Center. Dr. Rakesh, you are here now?
Yes, sir. I'm here, sir.
Yes. So,
Dr. Rakesh, would you mind renaming yourself? Please rename yourself.
Yes, ma'am. Yes.
Yashwant, you may share, please.
Yes, ma'am.
And if you could wind up in 50 minutes, okay?
Ma'am, it will be, it is very basic talk. So I have kept it very simple. We'll be discussing about few things only.
Go ahead, please.
Yes. So, I think my screen is visible.
Yes, sir.
Yes, visible, Dr. Yashwant.
Okay. Thank you, Asha ma'am, and all panelists. I will be discussing a brief about the genetic testing and who are the patient whom we test for genetic analysis. So the most common mutation, which is BRCA mutation. BRCA mutations are found in around 5% of our patients, and in this, around 10% of our hormone positive patients are having BRCA mutations, and 10 to 20% in triple negative patients, BRCA mutation is positive. So what are the other known factors? So 10 to 15% are known factors. Other are unknown factors. So you can see that breast cancer is very heterogeneous disease, comprises many mutations. So regarding the understanding genetic risk. So, Dr. Rakesh, I want to ask, who are the patient? Because we have to discuss related to gynae only, whom you consider genetic analysis when a patient with breast cancer comes to you. Who are these patients?
So, Dr. Yashwant, whenever I see a young female who are getting breast cancer, especially if it is a triple negative breast cancer, even if it is a hormone receptor positive breast cancer in a young female, I do advise for the genetic testing. I always inquire for the family history of cancer. So, suppose a patient is having the family history in the same family line, if a two or more are having the breast cancer, then also I'll advise for the breast cancer screening.
Okay. Dr. Sanjita, I want to ask you that do you advise if any patient comes with positive family history in your practice, anytime you have faced that, you have tell them directly to meet oncologists, or you yourself figure it out that they will require some genetic test?
Sir, we can first of all we should see the family history of other cancers like pancreatic cancer, ovarian cancer, any history of any blood, first degree blood, male breast cancer, if any first degree blood relative have breast cancer below 50 years of age, we can do risk assessment according to that, and then we can refer to oncologist.
So, what do you to all the gynecologists? I think to Dr. Kritika, what is a difference between a hereditary cancer and somatic testing? Like hereditary and how you differentiate, and what do you think? What are hereditary and what is somatic? Like, because BRCA mutations can be of two type. Like one is germline and another is hereditary. Another is somatic. So, what do you think?
So hereditary is basically which is carried on in the family, like first degree relatives, second degree relatives. If mother is affected and her mother is also affected, then the chances of the daughter getting affected is very high. So that is hereditary, but that accounts for only 10% of all the breast cancers. Whereas sporadic is the most common, which is accounts for 90%, and it can depend on various environmental and other factors also.
Yes. And as we have seen that BRCA mutation is a very broader term, and I will show in further slide that what other cancers it comprises. So these are for breast cancer, most important mutation is BRCA mutations, but there are more than 90 mutations also. So like Veronica ma'am was explaining in her talk, that patient with less than 50 year of age or other features, they need to be having BRCA testing. So BRCA testing, regarding BRCA testing, I will say that it has two parts. One is germline BRCA testing and one is somatic BRCA testing. So germline testing means mutation, as we know that BRCA is a tumor suppressor gene. So it prevents body from acquiring cancer. So these mutations lead to development of propensity for breast cancer. So germline means that it is present in every cell of a person, and somatic means they are random mutations. They are not present in every cells. So it can be two type of BRCA. One is germline, another is somatic. Why it in importance is this, I will explain in further slides. But in ovarian cancer, we also do somatic BRCA also. So BRCA testing help us. We as oncologists, it helps us in managing this patient, because BRCA leads to ovarian cancer also. Many in your experience, you would have seen that many patients present with ovarian mets or recurrence in ovary with family history. All this comes. So we have now more targeted drug, olaparib, which we use for high risk patient. And we have to do in BRCA positive for olaparib. Second is for triple negative patient with more than one blood relative with cancer, or patient with blood relative with cancer, or patient with family history of ovarian and pancreatic cancer or prostate cancer. These are all the factors where we do BRCA mutation analysis. So I want to ask other panelists also, what are their experience? Because this genetic testing were earlier costing 1.5 lakh, 2 lakh, but now they are affordable with per test costing 6,000 only, and many with free coupons. Many patients we do it free also, and this can have lots of implication in their therapy also, and also prognosis also. So I want to ask Chetna ma'am, do you think that yes, please.
Sir, I want to know that for this somatic mutation and germline mutation, which samples are we taking to differentiate ki this was germline mutation and this was somatic mutation?
Dr. Rakesh, you
From
want to
where
answer?
this?
So what we do, that germline is diseases in blood. So means in every cell. So we send the sample from blood. we take 4-5 ml of blood, and through blood only we are sending. So germline is OPD basis procedure. No need for biopsy. Wait for biopsy sample, and we can if one person comes positive, patient comes positive, then we have to check the other family members also. That's why whenever we send any sample, we always counsel our patient that if this test comes positive, then there are chances of ovarian recurrence also, and your family also has to be screened for this. For somatic, you need more of tissue. That's why biopsy sample is also needed for somatic. So, in your practice, what you have seen the dual like patient having breast cancer now developing ovary cancer or not? I want to ask Chetna ma'am or Preeti ma'am, anyone.
Yeah, I mean, we generally, yeah, we deal with, especially being in multi-specialty, we are getting a lot of references, but so far I don't remember seeing such patient. And with common, like what you call, you have that term, no? That combined ovarian and breast cancer, that syndrome. So I don't remember. Maybe we would have got, but I don't
But ma'am,
remember.
any patient because BRCA mutation positivity, germline BRCA mutation, it carries 66% risk of developing lifelong risk of
Ovarian
breast
cancer.
cancer. Yes, ovarian and breast. So concordance is very high. So such patients should be kept on follow up, and they should be screened. Dr. Sneha is also there. She is a medical oncologist in Bhilai Mittal Hospital. So, Dr. Sneha, you are there?
Yes, sir. Can you hear
Yes.
me?
So, Dr. Sneha, what do you feel? What is role of gynecologist in breast cancer and also in from diagnosis to genetic and everything?
A huge role because most of the ladies have the biggest trust on the gynecologist. They will present with a breast lump, they will present with any abdominal distension first to our lady doctors because there they feel comfortable. So once they have been picked up, that the lump has to be picked up early. And once the lump is picked up, the further treatment can be expedited so that they can be counseled immediately that they need to get investigated and treated. Because if it is left like that, then we are in trouble.
So, then this was the further proven in NCCN guideline that if as Veronica ma'am has shown in her slide that patient with family history, they all should be screened, and less than 50 year every patient should we should do BRCA mutation, because from therapy to prognosis to diagnosis to management, everything depends upon BRCA mutation. Even type of surgery, what type of surgery you want, that we should do, that also depends upon BRCA mutation. Because what happened that if standard of practice now is breast conservation surgery, most of our more than 95% patient undergo breast conservation surgery. Earlier we used to remove the complete breast, but now recommendation is there that conservation is the key. So for that, but in if patient is having BRCA mutation, then this patient with germline mutation, they will be having more risk of recurrences. That's why patient with BRCA mutation, we always we many a time counsel them for bilateral salpingo oophorectomy as primary prophylaxis. And we do also for many of our BRCA positive breast cancer patients as prophylaxis. And there are different screening guidelines for patient with BRCA mutation positivity also. So as Dr. Sneha said that gynecologist has big role because they are first center for patient care, and they should be knowing, as explained in our by previous speakers, about the lump and also how to proceed. And any as Asha ma'am was saying, that any suspicion in more than 30-40 year of age lady or atypical lump, it should be evaluated for by triple test for diagnosing breast cancer. And after diagnosis, family history is also very much important, and genetic testing is also important because it helps us in management and further treatment of patient. So regarding genetic testing or anything, what any questions you have?
No, can I ask?
Yes, ma'am.
Okay, just now I was talking to my medical oncologist and I came to know that there is a long panel where they check for mutations and there are a lot of things, not only BRCA1, BRCA2, so it's just a part of it. So
Yes.
as many as 150 mutations, is it?
Yes.
So what's the test called? He uttered something, I don't remember.
Ma'am, there are multi-agent means multi-gene NGS panel, next generation
Comprehensive
sequencing.
genomic panel.
Genomic panel.
Genomic
Yes.
panel, correct.
Yes.
Comprehensive genomic panel होता है मैम.
So now medical oncology is rapidly evolving. Earlier we were limited to only chemotherapy, but in advanced stage it is seen that many patients are not living longer, or disease is not getting control longer by chemotherapy alone. Then came targeted therapy, then immunotherapy, and many more drugs. So every day, every year in our pipeline, 10 to 15 drugs are coming, and all these are proven by randomized phase 3 trials. So whatever is coming in level 1 evidence, that only we are practicing. It's because yearly more than 100 molecules are coming, but whatever is coming in our international guidelines like NCCN guidelines or other guidelines, other recommended ESMO guidelines, that only we are following. So that BRCA, germline BRCA is standard of care in breast cancer. Similarly, BRCA and HRD panel is standard of care in ovarian cancer. So we are following the strict guidelines. Dr. Sneha, your comments.
Not clear.
I think you are mute.
Mute.
Hello, am I audible?
Yes.
Yes, you are audible.
Yes, ma'am. So basically, right now, initially BRCA used just for prophylaxis, whether we can, consider where we can do screening and where we can do the pre-testing and help patients avoid the malignancies. But now BRCA has a lot of role in treatment as well. So as sir has already explained in detail as to how we do the BRCA testing, what is somatic testing and what is germline testing, and whom we do these tests, the germline and the somatic ones. I think it is very prudent in today's date when it is so affordable that BRCA testing be done in most patients, and treatment is also affordable in the sense that sometimes it is even cheaper than the chemotherapy, and the toxicity of chemotherapy can also be avoided by just few pills to be taken at home. So that's quite an interesting development that has happened over the years with BRCA mutant patients. And as we already know that the BRCA mutant patients in breast cancer are a poor prognostic factor. So these drugs help in avoiding the recurrences, and for the ovary, where these drugs help in a maintenance therapy also and for treatment also, as well as for the fact that after first line therapy, we can avoid a recurrence, or we can at least delay the recurrences by using these drugs. So BRCA testing is like mandatory nowadays to be done in most patients with breast cancer and with ovarian cancer. Especially with ovarian cancer, all patients should undergo BRCA testing because it is treatment implicated. Over to you, sir.
Yes, thank you, Dr. Sneha. So I think we have Dr. Sneha has summarized in a very effective way. So genetic testing, this thing we are not doing only for it is not only pharma sponsored or we have costly drug for which we are offering, because it is changing our practice. In last 10-15 year of our practice from medical MBBS time, so we have seen that many patients come with regular family history of cancers. So if we would have done this test 4-5 year back, then we would have saved many life by screening. Or now what we are getting very advanced stage cancers, stage 4 BRCA mutant cancers, or patient with lung mets, brain mets. But I have 2-3 patients who are sisters is affected, 2-3 sisters are affected, mother is affected, still they were not evaluated and they were not treated. So these young lives of 30-year like ladies would have survived, or they would have detected, we would have detected in early stage and managed them. So it's this testing are very much now in every standard guidelines, and they are saving lives. That's why it is a standard of practice. Earlier only 1-2 labs are were doing, but now 10 to 20 around 15 to 20 standard labs, national labs and international labs are doing. So we are frequently sending, not only in breast cancer, also in ovarian and other related cancers or genetic analysis.
Sir, are you using any drugs in high risk patient in which BRCA is positive?
Yes, ma'am. We are giving patient who are not getting pathological remission post chemotherapy. They will be high
No,
risk.
no, sir. No, I am just screening. They are positive. At present, they are not having any cancer.
Then we are not not treating, but we were keeping them on stringent follow-up. So we are doing mammographies as scheduled, and ultrasound abdomen. This all we are doing screening, regular screening to prevent this cancer. And you would have heard about the Angelina Jolie also. She came positive, then she underwent surgery.
Mastectomy and bilateral mastectomy and oophorectomy.
Yes, ma'am, but that was not needed if she has option of a regular follow-up also, but she chose surgery. But many of our patient BRCA mutant positive, they are in follow-up also. So follow-up is also option, though that follow-up is very stringent. So many a time we feel in our scenario where many relatives are not compliant, then we offer them risk reducing salpingo oophorectomy.
Then in that pre-implantation genetic diagnosis, they remove that particular gene also, which causes. Preeti, madam?
Yeah.
Yeah, in that PGD, no, we had come across long back. So I think that must be regular now, that they had removed in that one family, no, that was for so many family members, it was positive. So they had that mutated gene, no, they had removed it completely.
But the thing is, when we are doing ART, we don't really patients don't remember that their first, second degree or third degree relatives were positive ovary or something.
This was one of the cases, I think, outside, not in India, but that was long back. So now I don't know ART how far it has come. I mean,
yeah, one of my patients, she has her she is a medical student, probably second or third year student. She is BRCA positive. Her family is strong, family history of this thing. So I asked her to go for regular checkup, and she has not turned up after that. But
you can
she
get
came.
predictive genetic testing, no, for her very much.
Yeah,
So you're
she's
doing, no, that.
BRCA positive. That I did. I sent her. I didn't do, but I sent her to oncologist, and they did, and she came positive. And
Oh, she
after,
also is positive.
yeah.
Good to hear all this, ma'am, that you are already seeing BRCA positive patients. So we have many. I will share the in group that is strict guidelines how to follow up the screen come positive patients. patient who are coming in routine screening BRCA positivity. How to screen? Because not only surgery, though surgery is not big surgery, but still now concept is of organ preservation. So breast is also a very important organ. So even in BRCA positive also, we are for many patients after a discussion we are offering breast conservation surgery, because in breast in more than 90 to 95% patient, our standard patient, they undergo breast conservation therapy. They don't
What
need.
is it? Nipple sparing surgery, something they're doing.
Yes, ma'am. Based on location of tumor and based on whether it is surgically R0 resection is feasible or not. So this we do, and even reconstruction is also very commonly done by all the expert surgeons, because now time is gone for doing big lymphedema and mastectomy. Now we are reconstructing breast also, and putting latimus dorsi and other flap also for other thing also. And also we BRCA positivity positive patient we are keeping on conservation also after counseling.
And how about, I mean, may I ask, what are the risk factors for male breast cancer?
Ma'am, most of the like it is not known, but obesity is the one of common factor, which is obesity is a common factor, or family history, though less than 5% of breast cancer is due to family history. So family history is one of the factor. Second is obesity, ma'am.
Many of them I have seen, like they have gynecomastia.
Yes, yes.
And then is that also a risk factor?
Yes, ma'am. Though not proven in trial, but it is seen that obesity is linked to breast cancer.
So regularly, I mean, you recommend that they should get operated, gynecomastia.
Ma'am, generally, if, cosmetic operation is like for female we do mammography to identify the lung, but for male generally like ultrasound will be good modality. So operation is for more for cosmesis, because gynecomastia is very common in male population also.
I've seen in the time, I have seen in the OT list so many times. That is why I'm discussing.
Yes, ma'am.
Then how do you deal with false negative?
False negative
Sometimes, yeah. What are the lab errors? Have you very often seen, because the lab, this BRCA1, BRCA2, whatever we are testing them for, should
yes,
have
ma'am.
good sensitivity.
Many a time, ma'am, what happened that variant of unknown significance it comes. So it is our standard practice that every medical oncologist always try to call the call the geneticists. We because many a time it is difficult to interpret the report. Just seeing negative or doubtful is not the key. It is always better to discuss with geneticists and the person who is reporting, because most of these tests in Raipur we are not doing, though we have many collection through MedGenome Strand and many good labs we are sending, more than 20 labs we are sending, different labs. So we always are in connection with particular doctor or scientists who can interpret it if we are in doubt. Otherwise they generally clearly mention. And we very commonly every 3 monthly or 4 monthly we organize our discussion with lab person also, because in medical oncology there are more than 100 type of NGS test, next generation sequencing, which we send for lung cancer, melanoma, sarcoma, ovarian and everything. So it is always better to discuss with the person who is reporting.
Sir, for the patient of gynecomastia, should we get their genetic testing also?
At present, recommendation are not there, and male breast cancer it is less than 5% positivity of genetic history. So, if any patient has family history, then I think, or a patient with a history of prostate cancer or family history of prostate or pancreatic cancer, because BRCA is not only in ovary and breast, it is also in pancreas and prostate also.
So better, why don't you advise all your male patients also with gynecomastia, self-breast examination, so that in case of any lump or any testing, they can pick up.
Yes, ma'am. I think for males, after because incidence is less than 1% compared to female, so I think there should be after few year. I think there will be guidelines. At present, no per se guidelines.
So during treatment after surgery, in tissue genetic expression test can it be different from the pre-operative status?
It is seen it is genetic profile can be different because if you have done in prelim you have done only BRCA germline. So breast cancer is not caused by only BRCA. There are more than 100 mutations. So like I have shown in previous slide that there are so many mutations. BRCA1 is in 30%, BRCA2 30%. Then there are so many P10, ATM, P53. So there are many things, and Lynch syndrome also, as we know that colon and uterine cancer, these patients also have high risk of cancers of breast. So if you have done only BRCA germline, then you will not get. But if you have done complete profiling in baseline and afterward, then it might have some difference, because there is also now concept of tumor evolution, that over 6 months of therapy it might have some evolution, or due to chemotherapy some minor changes can occur, but the basic mutation in this profile will not change much.
Then these risk reduction strategies, whatever we talk commonly,
Yes.
does not hold true when they have a strong positive family history, is it?
It is not, uh, ma'am, risk reduction surgery as BRCA testing
No,
is
not
not.
surgery, risk reduction. Strategies like we tell them to breastfeed. If
Yes,
they
ma'am.
get married early, they have children at younger age, and then they breastfeed them fully. All these used to be, I mean, those days I remember, but I was reading that this does not hold true. I mean, for strong positive family history. So this does not, I mean, work.
Yeah. Yes, ma'am. So
Like
apart
we
from that,
used to tell them to get tubectomy done
yes,
and all those things.
not only done, if they are not willing for tubectomy, then at least they should be in standard follow-up, like we do for our cancer patient also. We follow the standard.
Surveillance, yeah, surveillance.
So they should be in follow-up, routine follow-up of standard guideline. Then only it will be. Screening programs are picking in India. So hopefully over the year things will be much better now.
Sir, like Cowden syndrome, Lee-Fraumeni syndrome associated genes, TP53, P10, this all are autosomal dominant gene, we know. What advice we can give for next generation if we are suspecting this in previous generation?
So I think they are linked with many cancer, not only with breast cancer. So I think to stop the like other agent, like factors which can leads to particular cancers like breast, we can advise for that routine mammography which we do every 3 yearly from 45 year of age. Like for other cancer, we can advise for pap smear and other testing. Like for oral, we can say that quit the harmful smoking and alcohol, other factors. Then for prostate, we can follow after 60 year of age, 3 yearly or something PSA. For lung cancer, we can do low dose CT. So all these are such patient should be target, means they should be put in a particular guideline or enrolled with genetic counselor, where a plan can be formulated and they will be followed, because compliance is a big issue in such cases, and people become very anxious after seeing this BRCA in every report. So that's why even before ordering this test, we always counsel patient and family member also, that if it comes up positive, then there will be lots of implication for patients also and family also.
Then there was lot of hue and cry about this regular, this mammographies, the radiation exposure and all.
Ma'am, dose is very less, and it is seen over the trial that it is not linked with causing cancer. So dose diagnostic
Recently only
mammography.
I read that there were more cases which rather, mammography rather caused CA breast than to diagnose. Is it true?
Ma'am,
Yeah.
but the
Same
benefit.
paper I
Yes. So dose is very less, and risk benefit, because we are treating mammography is a standard of practice, and almost every female patient with diagnosed breast cancer, for planning surgery, we need mammography, because that needs for breast conservation surgery and our margin and everything, it is needed, because after chemotherapy.
Not only once, it's like annual. They do, na? That's for screening.
No,
Even
that is.
for high risk, low risk, so they are telling that you should not be doing annual MRI.
Yes,
Sorry,
ma'am.
mammogram.
Yes,
But
ma'am.
what about like those who are at risk, but still annual mammograms should be done, is it?
Ma'am, there also we have option of ultrasound. If patient has dense breast, then we can many a time switch to ultrasound for such patients.
For dense breast, they said mammogram, no? Or
Like
ultrasound.
that breast we can do, means we have option, like clinical examination is key in follow up post treatment also. What we do yearly mammography for 5 years, but dose of diagnostic mammography is very low. So in at big trial it is not found that it is causing per se cancer in such group also. And in BRCA mutation and high risk group per se, there is no trial which has proven that they are at more risk of getting breast cancer. So it is saving more life compared to causing.
Then there is this new technology, no, for mass screening of breast cancer that our
Yes,
hospital has
ma'am.
started
Thermal
in
screening,
mobile arm. Thermal screening. Yes.
but in trial, ma'am, mammography is better than thermal screening. That's why NCCN, ESMO, no guideline mention thermal
No, this
screening.
is only, see, when you go to the periphery and all, at least this thermal screening can pick up those cases which can come to the, a city and then get the mammogram, etc. done. But has anyone compared the results? Like when you say that it's positive thermal, do they really, what is the false positivity and false negativity?
Ma'am, I have per se organized 2, 3 thermal screening camp. So I can say that it is very difficult to convince this patient for comparison. And most of the patient who are in camp, generally they don't turn up in our clinical practice. So that's why per se experience is low. But in study of thermal screening, it is a good test. But gold standard is mammography.
This is just to pick up like a screening test so that, a diagnostic test will be
Yes, ma'am.
mammogram.
Yes, ma'am. But machine is costly. We have to arrange scheduling for technician and everyone. And many patient where we do camp, generally what happen, we are not able to follow this patient. They are not coming in OPD for biopsy and further. That's why our data is very low. But in all other study done in US, UK, they are saying that it has more than 90% sensitivity and specificity. So it is good test.
Then so
Ma'am,
we should
ma'am,
get
sir,
that test done very frequently, because it is not that this thing test is not that it is simple test, I believe, and if it can pick up more than 90% of the cases, then
That's a very
we
good
should
test.
make it we should make it very bring it to the guideline, because in we see advanced cases mostly. So if it can be picked up early, it is a recommended thing.
Yes.
ma'am, thermography, the
Definitely.
sensitivity is very less. It is 60% something, and the specificity is also very less. So I think other than thermography, a good clinical examination is a better option. Even a good clinical examination of the breast is much more better than the thermography. So that's
Okay.
why we usually do not recommend thermography as a screening procedure in till now it is India, it is not approved, ma'am.
In US, UK also the guidelines are not mentioning it because it's in different trial it has shown from 60 to 90, but it is for our setup it is difficult to follow patient also. Mammography is readily available in all center. We have 10-12 center here and most of the center have mammography, but thermography is not readily available. That is also a thing.
Where is Asha, madam?
Yes.
We had a lot of discussions.
Yes, yes, ma'am. Ma'am, it
So
feels very good
your
that.
suggestions for gynec.
Hello.
हाँ, बताइए शालिनी मैडम बोलिए.
Yeah, I am very much there. I'm very much there. Asha Didi also joined again. So you were telling something?
No, I'm
What
asking
is
sir, what are his tips for gynecologists, or like how it should go?
Ma'am,
I think the things go the reverse. Out of this panel, what is your take-home message? I want all the panelists to give the take-home messages before Yashwant will sum up.
It was reverse panel as Dr. MC Patel sir took once.
Yeah, but this is not a reverse panel, right?
Yeah.
So let the gynecologists give their take-home messages before the medical oncologists will give their messages.
I think we should start promoting BRCA genes screening because most of the gynecologists.
Yashwant, would you stop sharing, please, so we can have everyone on the same platform? Thank you.
Most of the gynecologists are not prescribing the BRCA genes for screening and for high risk. So we should now, as the cost is very less, only 6,000 SR is telling. So we should now promote more and more testing for these genes.
We should encourage our patients to come up with a good history, and we should encourage them to do self-breast examination and teach. Like if I am teaching my one patient, I ask them to teach all their relatives and their friends so that it propagates. And history and self-breast examination are the key for early pickup.
Yeah, we should teach every patient about the self-breast examination, and we should teach our senior staffs also, so that if we are missing, they should not miss it. So this should be taught to each and every patient, so that screening will be more safe.
We should have combined treatment for this gynecological cancer with oncosurgeon, oncologist. I think tumor board should be there where we can discuss these things.
I think patients should not neglect any risk factor, any high risk factor, or any lump or any changes they feel, and they should come immediately. Maybe if they're at a very low rural area, PHC, CHCs, everyone, MOs should be trained to at least refer the patients timely to higher centers so that they will be detected at an early stage and the treatment can be started. Most of the patients that we see are having advanced cancers, and in that case, nothing but the palliative management is to be done. So the basic education should start at PHC, CHCs. That is what I think.
See, when the patient comes, I mean, a proper history taking and family history, everything. I mean, sometimes we are in a hurry. So, jotting down the history properly, including family history of gynec cancers, and then, for their other gynecological issues also, when we take some decision for the management, so everything needs to be taken into consideration so that, sometimes they will not even reveal that mother had CA breast and all these things, so that we can, collectively keep these things in mind and then go ahead with whatever, what will be the best treatment for them, even when we plan surgery for them.
And I request oncologists also, if they find a case of CA pancreas or CA ovary or prostate, they should encourage the family screening.
Relative genetic testing, yes.
Yeah.
Dr. Rakesh, you are there?
Yes, sir.
What are your takes?
In my opinion, the BRCA actually, ideally, every breast cancer patient we should screen, and ovary cancer patient we should go for the BRCA testing. It is very important to know with the mutation because the family members might have 50% chance of having the BRCA positivity if the affected family member is a BRCA positive. Important thing is that you can start screening program as early as from age 18. So from the age of 18, a girl should screen for the breast cancer, that from the self breast examination. From the 25, when she is BRCA positive carrier, she should go for the screening. That is a MRI based screening for the breast cancer. And from the age of 30, she should go for the USG based screening for the ovarian cancer. So that's very important to know the BRCA mutation in a family member who are having the BRCA positive cancer.
And also, ma'am, I want to say that a palliative stage 4 patient in breast cancer, many of our HER2 positive patient stage 4, they are surviving for 5-6 years. So it's not that advanced stage means things will be done in 6 months, 1 year. But many patient, even hormone positive and HER2 positive, they are surviving for more than 5-6 years or even more than that. And now things are getting more affordable, more cheaper, and many good centers are coming. Earlier, comprehensive cancer centers were very less in Chhattisgarh, but now many good centers are coming up. So hopefully things will be much better. So it's not that patient had breast advanced disease, no money, then we have not done anything. So now many centers are offering good cancer care and comprehensive care, because comprehensive care needs involvement of medical oncology, surgeon, radiation, palliative medicine, then inputs from everyone, pathology and everything. So all these are coming up. So things are better for breast cancer patients and gynec patient also.
Thank you so much, Dr. Yashwant. It turned out more of a quiz for you, but I think all gynecologists have benefited out of it, and hopefully our viewers have also benefited out of it. So over to you, Shalini, for your formal vote of thanks.
Yeah, it was wonderful, dear faculties. The job done was great. And thank you, Dr. Yashwant, for a very useful panel for the gynecologist. The genetic part, we were less aware, and the things you enlightened us with all your inputs, and all the other oncologists joined from from Sanjeevani Care and Bhilai Mittal Hospital. And I really thank all my dear lovely panelists for joining in spite of your busy schedule and giving wonderful inputs. And I really thank Dr. Rajni Sao madam for her talk on self-breast examination, and Dr. Veronica for wonderful talk on lump in the breast. So now I want to add one thing. All of we must, our job is awareness of the public. It is not at the level of us, at the level of community, what we can do. This should be our motto, and this is this can be done whenever you need, whenever you get any chance to educate females regarding this genetic testing and everything. Self-breast examination, clinical breast examination, USG breast. These simple things can be done very easily to all the communities जो हमारे पास डिलीवरी के लिए भी आ रही हैं, या गर्ल्स पीसीओडी के लिए आ रही हैं, या इनफर्टिलिटी के लिए भी आ रही हैं, वो चाहे हमारे पास किसी भी कारण से आ रही हो, we should make them aware regarding this. I really feel this, and thank you everyone, all the chairpersons, Dr. Jofi, Dr. Vinya, and all our members and all our executives, all our group. I really thank Asha Didi for planning and making it workable, and
I'm going
we
to
could
stop
just do
live
in
streaming.
very short
I'm
span of
stopping
time.
live streaming.